The causes and effects of deinstitutionalization in America. Conditions prior to deinstitutionalization. By the mid-20th century, psychiatric hospitals had emerged as the most popular means of combating mental illness. There were hundreds across the United States, ranging in size and services offered. In 1955, it is estimated that there were 340 psychiatric hospital beds for every 100,000 Americans. Despite the large amount of psychiatric hospitals in the United States, by the beginning of the 20th century, ever-increasing admissions had resulted in serious overcrowding. In addition to overcrowding, federal and state funding was often being cut, especially during times of war, furthering asylums' inability to serve all those who required it. Asylums became notorious for poor living conditions, lack of hygiene, overcrowding, ill treatment, and abuse of patients. It became clear to the American public and government that the current mental health care model needed to be modified to better service those with mental illness. The most viable solution to the current problematic mental health care model for many was deinstitutionalization. Deinstitutionalization is the policy and practice of transferring homeless, involuntary hospitalized mental patients from state mental hospitals into many different kinds of de facto psychiatric institutions, funded largely by the federal government. Deinstitutionalization was credited with having two main benefits. 1. Reducing the population size of mental institutions by releasing patients, shortening stays, thusly reducing both admissions and readmission rates. And 2. Reforming mental hospitals' institutional process to reduce or eliminate reinforcement of dependency, hopelessness, learned helplessness, and other manipulative behaviors. There were several events that encouraged deinstitutionalization. Community Mental Health Care Act. The Community Mental Health Care Act of 1963 was brought to Congress by John F. Kennedy. The act approved federal funding for community mental health care centers in the United States. These new mental health care centers would provide community-based care as an alternative to institutionalization. At the centers, patients could be treated while working and living at home. While most of the proposed centers were never built and zero were ever fully federally funded, the new alternative of community care was more favorably looked upon by the public. This act increased deinstitutionalization because it directed federal money away from mental health institutions and towards community mental health care centers. Solder v. Brennan. Based on the Fair Labor Standards Act of 1938, the court ruled that patients in mental health care institutions must receive minimum wage whenever they perform any activity that offered economic benefit to the institutions they were located in. Previously to this ruling, mental health hospitals relied on the free labor from patients to operate laundry rooms, kitchens, and other necessities. These institutions deemed that labor a crucial part of patients' treatment, for it taught them responsibility and accountability. With this ruling, and mental hospitals now having to pay their patients for labor, costs to operate these hospitals rose tremendously. The rise in price led to an increase in the push for deinstitutionalization. The Roshan experiment in 1973. Conducted by psychologist David Roshan, the intent of the study was to test the validity of psychiatric diagnosis. The first part of the study involved Roshan and 8 other mentally stable researchers faking hallucinations to gain admittance into 12 different psychiatric hospitals across the United States. Once there, the researchers would return to acting normally and would tell the staff that they felt fine and no longer experienced any additional hallucinations. Despite being completely healthy, all researchers were forced to admit to having a mental disorder and agreed to take antipsychotic drugs as a condition of their release. While in the mental hospital, all but one researcher were falsely diagnosed with schizophrenia and were forced to stay an average of 19 days in intensive care. When Roshan shared the result of the first part of his study, many psychiatric hospitals took offense and challenged Roshan to send healthy people to their hospitals, confident in their ability to identify them. This launched the second part of the experiment. Out of 193 new patients, staffs identified 41 as mentally healthy and as sent by Roshan. However, Roshan had sent none. By eliminating the faults of the diagnosis in psychiatric hospitals, the Roshan experiment contributed to the movement of deinstitutionalization. American Association for the Abolition of Involuntary Mental Hospitalization, AAIMH. Founded in 1970 by Dr. Thomas Susan, George Alexander, and Irving Goffman, the purpose of the AAIMH was to abolish involuntary psychiatric intervention against individuals. The AAIMH was guided by the conviction that the practice of involuntary psychiatric interventions were a moral atrocity, similar to the practice of involuntary servitude. The AAIMH published a newspaper, The Abolitionist, to raise awareness and gain public support against involuntary psychiatric interventions. In addition to the newsletter, the AAIMH would secure help for individuals in need of legal assistance to get out of psychiatric hospitals and care they were forced into. The AAIMH encouraged deinstitutionalization by portraying psychiatric hospitals like a prison that kept patients captive in an inhumane way. This caused the public to look unfavorably upon psychiatric hospitals. Effects of deinstitutionalization. Due to the decrease in psychiatric hospitals caused by deinstitutionalization, there is fewer services and treatments available to the mentally ill. Compared to the 340 beds for every 100,000 Americans in 1955, there is currently an estimated of 17, with the number continuing to decrease. It has now been determined that the U.S. is over 95,000 beds short of reaching minimal standard for appropriate treatment. In addition, data for the NCS carried out in 1990 to 1992 reported that 54% of individuals with serious mental illness had received no treatment in the previous 12 months. The decrease in psychiatric hospitals caused by deinstitutionalization has also made getting care in facilities nearly unobtainable. The inability to get inpatient care has resulted in an increase of homelessness and higher incarceration of those suffering from mental illness. Now, over 1/3 of the homeless population suffers from mental illness. In addition to homelessness, a higher incarceration of the mentally ill in correctional facilities has been caused, where the mentally ill individuals are not receiving adequate care for their disorder. There are now 10 times more individuals with serious mental illnesses in jails and state prisons than there are in state mental hospitals. Deinstitutionalization has had some success. Outpatient care has been found to work terrifically for those who have had strong support outside of institutions, such as family and friends. Unfortunately, for those without support, outpatient treatment is ineffective and hard to maintain. In an attempt to combat this problem and give support outside of institutions, programs have been implemented to make supportive housing with full or partial supervisions and specialized teams, such as assertive community treatment and early intervention teams for the mentally ill. However, the cost of these support programs have been reported as generally equivalent to inpatient hospitalization, and the rehabilitation of patients receiving the support lower than inpatient hospitalization. The benefits that deinstitutionalization promised, reduced costs and better care, has yet to be seen. In fact, deinstitutionalization has done the near opposite of what it intended. It has limited service and treatment availability, made inpatient care nearly unobtainable, and decreased the rehabilitation rate for those suffering from mental illness, with little cost benefit. In conclusion, deinstitutionalization has failed as a solution to the problematic mental health care model in America.